Meeks for 5 minutes for the purpose of asking questions.
Thank you, Mr. Chair, and I thank all our witnesses who are here. It's a fascinating discussion. I could certainly ask questions for more than 5 minutes. As an ophthalmologist, I moved our small three ophthalmology practice to have a cash-based payment and a discount for paying cash because it was simpler for patients than trying to navigate through their insurance company. And I think it's interesting as we talk about consolidation and competition and PBMs that one of the biggest errors was in the establishment of Medicare having different reimbursement for different states rather than a single reimbursement for a single procedure or a single visit, which would have led to competition and medical tourism throughout the United States. And in 2010, when the Affordable Care Act was being implemented, myself and many other individuals warned that prices would go up, that premiums would go up with the passage of the Affordable Care Act. We especially were concerned about consolidation, hospital-to-hospital consolidation, physician practices becoming larger physician practices or being purchased by hospitals, and that we warned at that time that those procedures and things being done in doctors' offices would then move to hospital-based clinics, and the prices would go up. And it's not just the price goes up, as Dr. Ippolito said, the patient's cost share is also much greater, so their out-of-pocket cost is also greater. So consolidation increases healthcare prices and insurance premiums, as well as worsens equal access for care to patients in rural communities and medically underserved communities. And why is that? Because consolidation threatens competition. It doesn't matter if you have price transparency if there's no competition. So as you drive out competition, the value of price transparency in certain areas decreases. We've seen an increasing number of physician groups get absorbed by health systems, such as the recent purchase of Oak Street Health by CVS, and more physicians working in integrated groups, and more Medicare beneficiaries being directly affected by the high cost of integration. For example, the numbers of diagnostic and imaging lab tests being performed in a hospital has increased dramatically. We're pushed as physicians within a hospital to do things within the hospital. And this has led to Medicare incurring tens of millions of dollars of unnecessary costs, as was pointed out. And one of the things we talked about is a patient reform or payment reform that we think Congress should consider, which is site neutrality. And what other things could we encourage providers to remain, other things to do to remain providers to be independent, which could help with competition? Dr. Ippolito?
I'm sorry, could you repeat the last part of that?
What other things can we do, payment reforms can we do to encourage both, physicians to remain independent, site neutrality being one of those?
Sure. So, think about any payment policy that pushes in the direction of consolidation. So site neutral, making sure 340B doesn't push too far in that direction. That's one. At the state, while there's state policies, the federal government could in principle have effects on things like certificate of need, which some states still do have. We have tons of evidence on that at this point. We can talk about things like scope of practice, especially when you talk about rural areas. The natural level of competition that's going to be supported is going to be lower. And so you've really got to push everywhere you can. You've got to think about where can we realistically harness telehealth, right? Certain areas, mental health, things like that, you have a lot of opportunity to use that. But still, at the end of the day, I think about the U.S. healthcare system in sort of three buckets. There's the really competitive markets, big cities. There's the plausibly competitive markets, a lot of mid-sized cities that may have one big provider. And then you got rural areas. And you just do need to recognize that rural areas are a little bit different and be open to being a little bit more creative in those settings.
Thank you so much for that answer. And we've talked some about PBMs, and as a state senator in 2019, I put forward a bill in Iowa for transparency within the PBM and for the rebates, half of the rebate to go back to the person paying for the drugs. Got it through the Senate, but not the rebate part, the transparency part. We finally did not get it through the House that year, but we finally did. But 3 years later, we still don't have the transparency data coming forward, which we're finally getting to come forward. And as you all know, the three largest PBMs, CVS, Caremark, Express Scripts, and OptumRx, manage about 80% of all prescriptions in the United States, up from 48% a decade ago. And this is very pivotal in how we make decisions. We have one of the PBM tactics, and I won't talk about all of them, but it's something that Representative Carter and I have worked on, is the growing practice of misappropriating patient assistance dollars for the benefit of the PBM's bottom line. A middleman places increasing cost on patients by relying more on coinsurance and deductibles, copay assistance, an important bridge to ensure access to needed medications. So, Ms. Bartlett, what financial burdens do accumulators place on patients when copay assistance maximum is reached? I may have to have you submit that in writing because my time is
I definitely
expired.
will.
So
I've
if
got
you'd
the
submit that in
question.
writing, I would thank you. Thank you, Mr. Chair. I yield back.
Thank you. I think